today. My name is Susie Greenwood, and I am a clinical psychologist and clinical lead for the all-age eating disorder service in Kent and Medway. And I am here with my colleague Alice Childs. So Alice, I'll let you introduce yourself.
Yeah, hi everyone. So my name is Alice Childs and I'm a trainee clinical psychologist. So I'm currently on placement with the eating disorder service in Kent and Medway.
Thanks, Alice. And a huge thank you to Alice for sort of stepping in at the last minute as well to also sort of help with the presentation today. So our colleague Annie Cardinal will be joining us later, I hope, but she had to attend another meeting at 4 o'clock. So I'm hoping that she should be with us around about 5 o'clock. So she will be there, hopefully, when we're having the questions at the end. And as Lorraine said, the aim is to sort of perhaps have this presentation up to around about 5 o'clock, and that gives us plenty of time to answer any of your questions. As Lorraine said, if you sort of want to add them into the chat in case you forget them sort of later on, please feel free to do so. And we shall make a start. I can get this to start. There we go. So what we're going to sort of talk about today is just start by just giving you a little bit of an overview of NELFT and the services that we provide in NELFT, to let you know more about the Kent and Medway all-age eating disorder service where Alison and I work. We really wanted to give you a sort of overview of eating disorders that we treat. And to also just talk about the difference between disordered eating and an eating disorder. We also just want to tell you a little bit about the care pathways for children and young people in our service and what treatment that we provide. And also just to tell you a little bit about our early intervention pathway as well. So really trying to give you a really broad overview of our service and the range of eating disorders that you may come across with young people that you work with. And I suppose what we're trying to do is also just give some information about what signs to look out for. So I really hope that it is helpful today. So just to give you a little bit of an overview of NELFT, NELFT provide community health, mental health and eating disorder services across Kent and Medway, Essex, but also the North East London boroughs of Barking and Dagenham, Havering, Redbridge and Waltham Forest. But NELFT also provide the children and young people's mental health and wellbeing service and the all-age eating disorder service across Kent and Medway. And this contract sort of was won in 2017. So these are the different services, just to give you a bit of an overview, that are available to young people and their families across Kent. There's the emotional wellbeing mental health service for children and young people, and that provides sort of mental health advice and support for young people and their families. There's the sort of children and young people's mental health services, or what you might know as CAMS, and we have locality teams including Maidstone, Medway, Tunbridge Wells, Canterbury, Dartford, Ashford, Thanet, Swale and South Kent. We also have the neurodevelopmental and learning disabilities service for children and young people, the eating disorder service, also the Kent and Medway Adolescent Hospital. That's an inpatient mental health unit for children and young people in Kent and Medway, and it's a general adolescent unit with an eating disorder pathway. And there's also the mental health support teams, which obviously is a new government initiative to help increase children and young people's access to support for emotional well-being and mental health. So that's just an overview of the different services. And then a little bit more about the sort of our service and the aims of the eating disorder pathway. So the all-age eating disorder service was commissioned from September 2017. It's an all-age care pathway. So we take referrals from people from the age of 8, but across the lifespan. And we offer NICE concordant treatment. And NICE stands for the National Institute of Clinical Excellence. And that's the public body of the Department of Health and Social Care in England that offers guidance and recommendations for treatment based on evidence-based evaluations of efficacy. So we are a multidisciplinary community service. So we run sort of Monday to Friday, 9 to 5. We offer sort of intensive community support. And we have a sort of clinical staff with a significant eating disorder expertise. And I'll go into that in a little bit more detail of the different disciplines that we have in our team. And we're also going to be talking in more detail about the following eating disorders that we treat and assess. So, as I said, we accept young people from the age of 8, but then offer a service for children and young people and adults across the lifespan. And we are offering treatment for those with anorexia, bulimia, binge eating disorder, and OSFED, which stands for Other Specified Feeding and Eating Disorders. And we'll go into those in more detail. Alice is going to go through those shortly. So in our team, we have the strategic and clinical lead, which is Annie. We have our head of service. We have our team manager, who is Kim Faramond. I'm the clinical lead. We have psychiatry input. So we have consultant child and adolescent psychiatrists, but also adult psychiatry. We have a pediatrician and psychologists, psychotherapists, family therapists, dietitians, a range of nurses, CBT therapists, and we also provide an outreach service, which is sort of our clinical support workers who are able to visit some families and young people up to twice a week if that's needed. And the type of support that will be offered will vary depending on the type and severity of concern. So just to give you a little bit of an overview in terms of, there's the NICE concordant treatment, which might be individual therapy or group therapy, family therapy, or guided self-help. There's a psychiatry and medical assessment and reviews, dietetic advice and support, and within that we also offer a lot of psychoeducation. So we offer dietetic psychoeducation groups that people can attend online, and that might be on certain information topics, like on carbohydrates, on things like fats, just to dispel some of the myths and to support the NICE concordant treatment that people are receiving. We have duty and crisis support. So we have a duty team of up to 3 people a day who screen and triage the referrals that we get into the service. And we also have outreach support, which I just spoke about. So I suppose what we're going to start off by just talking about is really thinking about what is an eating disorder. So when we're thinking about the sort of different eating disorders, we're looking at a diagnosable set of symptoms that affect daily functioning and have a significant effect on physical health. And as I said, the eating disorders that we treat are anorexia, bulimia, binge eating disorder, and OSFED. But what I want to do first of all is just to talk in a little bit more detail about what is disordered eating, because there is a difference. So I think sometimes we sort of, we use these sort of terms interchangeably sometimes, but it's good just to get a bit of clarification on it. So disordered eating is where you might see that somebody is restricting what they eat. They might be going on a diet. They might be suddenly exercising quite a lot. They may be, I'm just going to move this so I can actually see my slides, be very, very preoccupied with food groups. They might cut out sort of whole food groups, maybe sort of carbohydrates or fats. But the difference between disordered eating and an eating disorder is that disordered eating has a limited effect on physical health and daily functioning. So that if somebody isn't able to use those disordered eating behaviours, the distress or the anxiety would be quite limited, and it wouldn't have a significant impact. So you might notice that somebody might cut out a particular food group for a while, maybe for a week or 2, but then they go back to sort of more regular eating again, or they do it for just a short time or sometimes or part of the day, but it's not consistent. And the main difference is the limited effect on physical health. There may be body image difficulties and weight concerns if somebody has disordered eating, but that it will be within a normal population level of concern. So we have to bear in mind that Actually, when we're working with young people or with adults, and generally in the society that we live in now, there's a big focus on appearance and body shape and fitness and how we look. So it's very normal that if you spoke to anybody in the sort of general population, the vast majority, if you said to them, are you happy with your body? Is there anything that you'd like to change about your body? A lot of people, the majority, are going to say yes. So we always have to bear that in mind, that actually body image dissatisfaction is quite common. What we're looking at in an eating disorder is when there's a significant disturbance, so that it has a significant impact on what they're eating, if they're losing weight, if they're using other behaviours, that has a very significant impact on their physical health and their daily life. So again, with disordered eating, there may be isolated or occasional incidents of behaviours like vomiting or using laxatives, but it's not that regular. There may be emotional overeating. There may be pica, which is, if you haven't heard of pica is where somebody might be eating items that are not typically thought of as food, and they don't contain significant nutritional value. So it might be dirt or hair or paint chips, things like that. Orthorexia and sort of clean eating, that's an obsession with eating foods that are considered to be healthy. Sort of veganism, all these three things can become forms of disordered eating, but they wouldn't reach the threshold of an eating disorder if there was a limited effect on physical health or daily functioning. This I'm just want to focus on just briefly is really the other thing that we would be looking at when we get referrals in and when we're working with people with an eating disorder is also being able to identify the differences between disordered eating and an eating disorder. And because sometimes you might see disordered eating that might occur in the context of a different psychiatric disorder. And the way to distinguish whether it is disordered eating or an eating disorder is mostly to do with the intention and function of the eating behaviours. So, for example, if the eating behaviours are a way of eliciting care, or a way of avoiding perhaps real or sort of feared abandonment, then that is not what we would typically see with an eating disorder. So, for example, you know, you might have somebody who is using an NG sort of nasogastric tube, and that's sort of supporting their identity as a person with an eating disorder, or their restriction is sort of bringing quite a lot of further support around them. What we know with sort of anorexia presentations is it often tends to be what's called intrapsychic. So actually people will not want people to intervene. They do not want to bring any attention to it. They do not want, they would rather not have support. They would rather try and say that I haven't got a problem. And often it's very much about not perceiving that they do have a problem. So we're trying to look at, you know, is this perhaps, what are the drivers of the eating behaviours? Also, we're looking at if there is body image disturbance, is that actually part of a more global sort of distorted sense of self? If somebody sees themselves as being a very unlovable, flawed, bad, sort of unworthy person, and therefore the sort of body image disturbance is more in the context of that than an eating disorder. If it's an eating disorder, the sort of eating behaviours are more around control and perfectionism drivers. So that's what we're trying to distinguish. And we're also trying to see sometimes disordered eating behaviours can serve as a sort of way of regulating emotions. So if somebody's very dysregulated, if they can't manage their emotions, sometimes the disordered eating can be a reaction to that. And we just have to be very careful about really making those distinctions, because if we're offering eating treatment for an eating disorder, we may, and it's actually more disordered eating, we could actually be treating the wrong sort of condition. And actually what we're finding is actually, if you're then treating the eating disorder, what can sometimes happen is if it is around emotional dysregulation, another behaviour pops up in its place. So, for example, maybe if you support somebody to be able to eat regularly, that then actually the self-harming might increase. So as one behaviour goes down and gets treated, another one pops up. And sometimes I've worked with people, you might sort of a bit like that whack-a-mole sort of analogy, where you treat one and then another one pops up in its place. And that's what I'd be thinking, is it a different disorder? I'm now going to pass over to Alice, who's going to just go through the different eating disorder diagnoses that we treat in our service.
Thanks, Susie. Yeah, so to start with, I know Susie's mentioned a few things about anorexia already, but just thinking that a diagnosis of anorexia nervosa is primarily focused on those who have a low body weight, and so that their body weight is sort of maintained or kept at least 15% below that which would be expected for their kind of age and also their height, or if their BMI is 17.5 or less. So we sort of consider BMI more for our adult patients, but with young people, because we know they're still growing and developing, we tend to use weight for height instead, and that's where you might see a percentage instead, and that's very much based on what their height is, what their age is, and what their gender is, and what the sort of norms are for that, where we would expect them to be. So there's intentional weight loss by avoidance of kind of fear foods or fattening foods, severe restriction of their food intake, so really kind of cutting down what they will eat within a day, self-induced purging, and kind of compensatory behaviours as well, so maybe kind of excessively exercising or using appetite suppressants or diuretics, things to kind of compensate for any food that they might have eaten. And they also have body image distortion, and that intense fear of weight gain, and persistent behaviours that might sort of interfere with weight gain. So almost anything to really prevent weight gain from happening. In women or girls, we will see a loss of their menstrual cycle, and that will be due to the kind of low body weight. And in men, it also mentions kind of loss of sexual interest or potency. And because of the low body weight and the body not getting kind of the energy and things that it needs, you might see that puberty is delayed, or it might even kind of be stopped completely during that time. As Susie also mentioned as well, that sometimes we can think of anorexia as being quite kind of secretive. It's not really a disorder that is easily communicated, and sometimes people kind of struggle with their kind of insights, so they might kind of say, actually, well, I don't think this is a problem, or I'm not as bad as this person, or something like that. So sometimes there can be quite a lot of sort of denial, and a lot of work is actually sort of getting to realizing that actually it's quite serious, actually. Can you move the slides on, please, Susie? Thank you. So anorexia nervosa as well also has the highest mortality of all mental health disorders. So it's really important to kind of be picked up early. 54% of deaths are kind of secondary to different complications of the anorexia nervosa. So thinking about kind of cardiac complications, things like that. But 27% are due to suicide. There's long-term complications in terms of bone health and fertility, so osteoporosis, osteopenia, and infertility. And we know that in terms of kind of making a recovery, the full recovery rate is about 46%. People making a partial recovery is 33%, but we know that around 20% of people actually don't recover. And the average duration of the illness, and that's for across all ages, so young people and adults, is about 8 years. Research has shown that there's a poorer prognosis if the duration of the symptoms before the point of accessing help and before receiving treatment is more than 3 years. So again, that kind of early recognition is really important, so that people can receive treatment within as quickly as possible, and within a time frame where we can maybe boost those kind of recovery rates. And comorbid mental health disorders are quite common, so you might see anorexia nervosa with something else. Next slide, please, Susie. So bulimia nervosa, that is where you might see recurrent episodes of binge eating. So what we mean when we say binge eating is eating in a very short kind of discrete period of time, an amount of food that is kind of significantly larger than most people would eat during a similar period of time and under similar circumstances. And that's what you'd be looking for, really, is that it's kind of really significantly larger, and a sense of lack of control over eating during the episodes. So people will say that they kind of feel out of control during that time. There's also recurrent compensatory behaviour in order, again, to prevent that weight gain. So maybe after a binge, for example, you might have self-induced vomiting and then use of laxatives, diuretics or other medications, or again, those kind of compensatory things like exercising excessively or then kind of fasting or restricting. And the binge eating episodes need to happen at least once a week for at least 3 months, and that's to get this diagnosis. And as with anorexia as well, the kind of self-evaluation, so kind of what someone might think of themselves or their kind of self-esteem is quite largely influenced by body shape and weight, and that's above and beyond how much that might kind of typically influence someone's self-esteem. Next slide, please, Susie. So again, so just going into a bit more detail about those sort of recurrent episodes of binge eating. So this is binge eating disorder, which is different from bulimia, in that you have the episodes of binge eating associated with at least 3 of the following. So eating much more rapidly, more quickly than normal, eating until you're feeling uncomfortably full, eating large amounts of food when not feeling physically hungry, eating alone because of embarrassment around that, or feeling disgusted, depressed, or very guilty afterwards. And all of these things cause quite marked distress for the individual. And again, so these binges need to occur at least once a week for at least 3 months. But the difference between binge eating disorder and bulimia, for example, is that these binges are not then associated with the compensatory behaviours. So the binges sort of occur on their own and then aren't particularly followed by any of those kind of restrictions or excessive exercising or purging, that sort of thing. Next slide, please. And then finally, we come to OSFED, which, as Susie said, stands for Other Specified Feeding and Eating Disorders. And that is a kind of category where it's when someone presents with feeding or eating difficulties that still cause that clinically significant level of distress and that sort of impairment in their sort of daily life and on their physical health, but that they don't meet the full criteria for any of the other disorders just mentioned. And what we know is actually it's the most commonly diagnosed eating disorder of them all, but it's no less serious than the others at all. And when a diagnosis is made, it sort of needs to be made more specific. So the reason why the presentation might not meet all of the criteria of one of the other diagnoses. So for example, bulimia nervosa, but low frequency of binging, for example. Next slide, please. And just to give a bit more kind of clarity on that, and some examples. So what you might see in OSFED diagnoses is things like atypical anorexia. So that's where all of the criteria for anorexia nervosa that I mentioned before are met, except that despite maybe significant weight loss, the individual's weight might still be kind of within or above the normal range. So they would still be sort of considered a sort of normal or healthy weight, but they are having that significant weight loss. Which will still then impact on their physical health. And then you might have bulimia nervosa, and again, thinking about of low frequency or that limited duration. So it might meet all of the criteria that was mentioned previously, except that the sort of binge eating and the compensation might occur less than once a week or for less than 3 months. So it just doesn't meet that one part of the criteria. The same with binge eating disorder, really. So it might meet all of the other criteria apart from that, those parts about frequency. And then you have purging disorder, where you have the recurring purging behaviours in order to influence someone's weight or shape in the absence of binge eating. So kind of what we talked about before with binge eating is you might have the sort of binges and then kind of in compensation to that, the purging after, whereas in purging disorder, you don't have the binges, but you have a lot of the kind of repeated purging behaviours. And then this is just a slide just to demonstrate the sort of prevalence. So, so actually just to show really that disordered eating is more prevalent and more common. And as we said, then we know that OSFED with 47% is then the kind of most diagnosed eating disorder. So if someone does start to present with eating difficulties, it's thinking that in terms of kind of the prevalence, that in the first instance, it's probably more likely to be disordered eating, with the others kind of following. Oh, Susie, you just need to unmute yourself again.
Sorry. Let me just put that back. Oh, sorry. There we go. Running ahead of myself. So we thought it would be really helpful just to think about what are the early warning signs of an eating disorder. And here I'm just going to talk through all the different things that we sort of generally ask people to think about, to notice, to be aware of, and to monitor. So first of all, is just thinking about, are you noticing changes in eating behaviours? So if we think, and obviously today we're very much focusing on children, young people, young adults within this sort of network. So what you might be noticing is somebody more anxious around eating. Or you notice actually that they're a little bit more obsessional around food, perhaps wanting to eat at very specific times, perhaps asking lots of questions about what's in the food, wanting to know a lot about the nutritional content, or checking packages for the nutritional content of food, perhaps avoiding foods that they previously ate, or cutting out particular food groups like carbohydrates or dairy. You might notice things like somebody eating very, very slowly, or cutting food into very, very small pieces, or avoiding eating around other people. And something else that we tend to see is that actually hiding food can be sort of something that you tend to see, or being very secretive about what they've eaten, or throwing away food, perhaps throwing away, packed lunches at school, or just not having school dinners. And of course, at the beginning, people might not notice. Perhaps taking frequent trips to the bathroom after meal times is something that you just need to be wary of, but also perhaps if somebody's suddenly wanting to prepare all their own food and doesn't want other people to cook for them. So they're the sorts of things that we might look out for. We also watch out for young people who might get fixated on the healthy eating talks that you receive in years 2 and year 6. Now, it's not for all children, but for some children, particularly those who have a history of anxiety, they can be very worried about the healthy eating talks that they get. And you might find that parents or school may notice changes in their eating behaviours after these talks that can lead on to other disordered eating behaviours, such as only wanting to eat foods that they see as being very healthy, perhaps avoiding sugary foods or high-fat foods, and perhaps some of the other changes that I just mentioned in the previous category. I suppose we're also looking out for young people who are suddenly going on a diet, and if there's lots of talk around food and healthy eating, and or perhaps lots of talk around their body, and perhaps if they're wanting to avoid certain ingredients in meals, are they asking about how much oil is somebody putting in the family meal, or perhaps suddenly wanting to become vegan, or asking what the family meal will be? Lots and lots of questions around food that hadn't previously been there. We're also looking out sort of for some personality traits that are thought to be risk factors for developing an eating disorder. This doesn't mean that anyone who has low self-esteem or perfectionism means that they will develop an eating disorder, but we know that it can be a vulnerability factor. And what we do know with eating disorders is there is no one single cause for an eating disorder. It's often a sort of multiple range of different factors that sort of work together to in terms of the vulnerability factors, but also perhaps triggers that may make somebody more likely to develop an eating disorder. For example, if we think about what's happened over the last 2 to 3 years with the pandemic, and we've seen a significant rise in referrals in eating disorders services, but also an increase in admissions to acute hospitals for periods of refeeding, increased sort of referrals to specialist eating disorder units. And when you think about that environment where you had maybe somebody who may have been quite anxious or may have had certain personality traits, and then everything changed sort of overnight in terms of life, in terms of going to school, changing routine, nothing to do. There was a big focus everywhere on the media and on TV and radio about just focusing on getting healthy, getting fit, what you're eating. So when you look at all that together, there was multiple factors that perhaps led to that increase in eating disorders that we saw. When we're thinking about low self-esteem, that's sort of feeling bad about yourself all of the time, lots of self-critical thinking that can get in the way of normal life. And perfectionism is that sort of setting yourself extremely high standards where nothing is good enough, and perhaps judging how good you are, perhaps your sense of self-worth very much on your achievement. But there's also things like anxiety, sort of very high levels of worry and stress. So they're the sorts of things we'd also be looking out for, just certain personality factors. But also we're looking out for things like, what we know is actually sort of low resilience and high distress around eating. We know that actually for those young people who perhaps have always had a tendency to avoid harm, who struggle to tolerate uncertainty, who perhaps have very obsessive sort of style of thinking, perhaps always overthink everything, struggle to see the bigger picture, maybe that sort of difficulty thinking flexibly, very much that black and white, all or nothing thinking. That's again what we're looking out for. That could perhaps make somebody a little bit more vulnerable. I think everyone's very aware that body image issues are part of what we would see in an eating disorder. In fact, that's, as Alice saying, that's one of the key diagnostic criteria, that there is significant body image disturbance. So that's really seeing oneself as overweight or feeling fat or saying that they're fat when actually they're really not, seeing themselves as bigger than they are. So what we'd be looking at in terms of early warning signs is perhaps just more concern and distress around body image. Are they suddenly starting to check their body? And that might be things like looking in the mirror, perhaps measuring parts of their body, trying to sort of wrap their fingers around their wrists or their legs, trying to pinch parts of their body, wearing baggy clothes or comparing themselves to others. Also, we're looking at what's really important is looking at a young person's social media use. So who are they following? What sites are they accessing? And we know that what the sort of problem that we have these days is that you might sort of look one time, and then with the algorithms that we have on these social media platforms, it means that then the young person is targeted, because then lots of different articles and feeds pop up on their account. So, and that might be around sort of what to eat, fitness. So once you followed it a little bit, it then sort of follows you. So it's very difficult to get out of. But how much time are they spending on social media? They're looking at sort of eating disorder, anorexia, sort of and something that we need to think about. So just excuse. I'm assuming that it's okay. So if everything's okay, I'll still just carry on. So we're also just looking about how somebody is in terms of their relationships and how they are sort of socially. Are they suddenly seeming quite withdrawn? Are they seeming sort of like different to how they would normally be when they're around other people? For a young person, have they stopped seeing their friends? I think that's something I think is a really important thing. Are they actually within the family? Are they still sort of wanting to spend time with the family, or are they spending an awful lot of time in their room? Now we know that actually for during sort of adolescence, it's very normal that sort of wanting more independence and spending more time on their own. But we're looking for a change over time. And I think particularly with that, what we know with an eating disorder is that as when the eating disorder thoughts get much stronger, it means that people become sort of less interested in normal life and become very, very preoccupied with their eating and fitness and a way of controlling their weight. So they can become quite socially withdrawn. But also changes in physical health, and that's a really important one that we're going to be coming on to in the next slide. So weight loss, fatigue, dizziness, chest pains, muscle weakness, abdominal pain, feeling cold, or just generally looking unwell. Perhaps at school, problems with concentration, changing, perhaps struggling more with their work where they weren't before, and also changes in menstrual cycle for girls, for the reasons that Alice outlined before. Just going to talk briefly about the medical complications that can come with an eating disorder. That includes cardiac abnormalities, especially when you're very low weight, or if you're using self-induced vomiting as a compensatory behaviour or laxatives. And that's why it's really, really important to get an ECG, and also to look out for if there's very slow pulse, because we know the impact on the heart. So this is something that we run, as I said at the bottom of the screen there, that's why it's so important to work in a multidisciplinary team. And we run regular physical health clinics to monitor medical risks. And part of that would be offering an ECG clinic that we run in Maidstone. We're also looking at the physical side effects of frequent vomiting that can include damage to the esophagus. It can also include tooth decay. We would also be looking out for something called Russell's sign, which is a telltale sign of self-induced vomiting, where you might notice scratches on the back of the hand that's caused by when somebody puts their finger to their throat to induce a gag reflex. We're also very much looking, the medical complication would be around bone health that actually Alice also talked about. Osteoporosis, which is caused by long-term being very underweight. And in our service for children and young people, if they have not had a period for 1 year, then we would be requesting that they have a bone density scan to really investigate that further. We're also always assessing risk in terms of refeeding syndrome. And refeeding syndrome is a serious and potentially fatal condition that can occur during refeeding. And really it involves metabolic abnormalities that can occur when somebody who is malnourished begins feeding after a period of starvation or very limited intake. And this is not dependent on weight. So somebody can be normal weight, but if they've really been gone through a period of starvation of very, very limited intake, they would also be at risk. So there's no distinction by weight. And it's basically caused by sudden shifts in the electrolytes that help your body metabolize food. So this is something that we are always looking at in terms of when we assess people and when we're sort of seeing people weekly is just checking for the risk of refeeding. We're also looking at electrolyte imbalances, because purging behaviours can often override the body's natural ability to keep their electrolytes such as sodium, chloride, potassium in normal balance. And the side effects of low electrolytes can be extremely dangerous. So that's why we would always be looking at that. Low blood pressure, especially when low weight, because it could put somebody at risk of fainting and collapse. So again, that's something that we would be, in our physical health clinics, we would be measuring somebody's blood pressure, their pulse. We'd do blood pressure from sitting to standing, and also be just testing their temperature as well. Just quickly, we're going to talk about the MEAD, which stands for Medical Emergencies and Eating Disorders. And this is the guidance on recognition and management. It replaces the marzipan and junior marzipan. It sort of was launched last May, and as an all-age eating disorder, it does provide sort of guidelines for all ages across all eating disorders. And the idea about it is really to focus on the importance across all healthcare settings for all clinicians to be able to recognise how to manage medical emergencies. So I've just put the sort of link here, but it really provides a traffic light rating system to manage risk in anyone presenting with an eating disorder. So it rates it from, you know, green, which is low risk, amber, medium risk, and red, which is high risk. Very briefly, I just wanted to show you an overview of a patient's journey through an eating disorder service. So what would happen is that they would be referred to our service, and that's can be a self-referral or from the GP or school or other services through our single point of access. The referral will be triaged by our duty team. And if we think that they sort of meet the entry criteria, then they would be offered, and they are over 8, they will be offered an assessment. They would then have a very detailed assessment by a specialist healthcare professional. If they don't meet criteria for our service, if we don't think that it's an eating disorder, people will be signposted to other services. If they do, then they will be allocated to a care pathway. And then receive nice concordant treatment, and then hopefully that will be successfully completed and then discharged. And I'm now going to pass over to Alice. Thanks, Alice.
So I'm going to talk a little bit more about the treatments that we offer. So once someone has been sort of accepted by our team. And so as Susie said before, all of the treatment that we offer is NICE recommended, so National Institute of Clinical and Health Excellence, and that is based on significant amounts of research which demonstrate that it's the most efficable and has the best sort of outcomes, really. So for young people, family-based therapy is the first line, the first recommended treatment for anorexia nervosa and bulimia nervosa, and that's typically 18 to 20 sessions over 1 year. But in some cases that might sort of be ineffective, or there might be reasons why we think that might not be the most useful. And in those circumstances, we then offer individual CBT for eating disorders. Susie's just popped the link there for the kind of NICE guidance. So what is the recommended sort of pathway and treatment for eating disorders? Regular physical health monitoring is part of the treatment, and that is established from the very beginning, really, because of those physical health risks. And as also mentioned, we also offer support from our dietitians and also outreach, which can include sort of home visits, having like meal modelling, or kind of having snacks together, that sort of thing. So a bit more sort of assertive. Next slide, please. So as I mentioned, the kind of physical health monitoring is established early, and as Susie said, we sort of have regular clinics for that. So that's sort of regular weighing, blood pressure checks, pulse, and if needed as well, we also have regular blood clinics. So people might have regular blood tests as part of that as well, that will be monitored by our doctors, our psychiatrists. Family-based treatment has 4 different phases. So kind of phase 1 and 2, sort of engagement and development of the therapeutic alliance. So really kind of getting to know each other and working together and helping the family to manage the eating disorder. So to begin with, it's about kind of moving the control around sort of eating and what the intake is away from the young person, and supporting the parents instead to have that control and to promote kind of that weight restoration, so reducing the kind of symptoms that are associated with the low weight. And we will give psychoeducation, so give lots of information about the kind of different effects of malnutrition, the effects of starvation on the brain and the kind of patterns of thinking, and emphasising that it's the role of the family in helping the person to recover. So it's not sort of blaming any individual or family, but just thinking that actually, for example, anorexia is sort of something that's external, and it's kind of the whole family working together to beat anorexia. And we support the parents in kind of taking that kind of central role, taking that control, and being very clear on what everyone's roles are. At this stage as well, these first two stages, you might understand the impact on the family and thinking about kind of roles and how they've changed since the family have begun to manage the eating disorder, and even kind of the role of the eating disorder in the family and how everyone's tried to sort of manage it so far can kind of cause changes in those dynamics. In phase 3, we kind of, after we've seen some weight restoration, it's about handing that control back over to the young person and helping them to sort of supporting them to move back to eating more kind of independently, having a bit more of that sort of independence and spontaneity, but also supporting the family to manage any other issues that might come up, thinking about adolescence or young adulthood, and just thinking about how this sort of impacts the family and the response to the eating disorder. And then in phase 4, it's really about kind of the ending, thinking about future plans and discharge, and just helping the family move away from illness and crisis and back to sort of a normality, a pattern of normality, but also supporting families to kind of think about what triggers there might be, or kind of early warning signs or things, so they know how to sort of manage any difficulties that might come up in the future. And then additional to that, for some young people, we have developed a modular program. So for young people who are in phase 3 and 4 of family-based treatment, and through family-based treatment have restored weight to at least that 85% weight for height, and that's been maintained for at least 4 weeks, we might consider offering them some individual sessions. And so the modular program was really sort of developed from feedback from young people themselves, what they've been telling us, and also an audit of our questionnaires, our outcome measures. So our outcome measures were sort of showing that after weight restoration and at the point of discharge, young people were still scoring in that clinical range for their concerns about their body image, so weight and shape. And we also know from research that those factors, alongside others that are risk factors for developing an eating disorder, so things like kind of that self-criticism and the perfectionism, things that Susie sort of mentioned before, we know that they sort of persist after treatment and after weight restoration as well. So with that in mind, and really listening to what the young people and their sort of questionnaires and outcomes were telling us, we developed the modular approach. So next slide, Susie. And this is really where young people can have a bit more control over what they'd like to think about, maybe in individual sessions, where family-based treatment is very much focused on restoring weight. This is a bit more of a young person's chance to sort of think about what's important to them or what would be the most helpful for them. So in sessions 1 and 2, we sort of get to know the young person and have a think about you know, what their kind of presenting challenges are, what might have led to that, and what they might still be finding quite difficult. And they can choose from any of those 7 different modules. They can choose up to 3 really, and it's a bit of a pick and mix, so whatever feels most important to them. So we've got media and body image, so thinking about kind of body image, their relationship with body image, but also the influence that kind of media, social media might have, and how they can have a kind of healthier relationship with their use of social media through that. Identity, so for a lot of our young people, their eating disorder has become quite a large part of their identity, or quite a large part of their life, and as we talked about before, sometimes there's that sort of over-evaluation of appearance being a large part of identity and self-esteem. So it's kind of thinking about their values, their interests, and what makes them them, and kind of supporting young people to really kind of have a think about that. We've got thinking styles, so thinking about how patterns of thinking that might kind of be quite unhelpful actually, or might kind of lead to sort of negative thoughts about ourselves, and how to challenge those really, but also thinking about rules for living, because a lot of young people who are struggling with an eating disorder have a lot of rules for living, around eating, around control, around the perfectionism and things like that. So it can be really helpful to maybe think about those and how kind of helpful or unhelpful they are. And we've got body checking and body avoidance, and along with that, body functionality and acceptance. So thinking about that kind of body satisfaction, but also through the weight restoration, young people feel like their body has changed quite significantly. And so it's kind of thinking about their relationship with that as that has changed, and how they can have a more positive relationship with their body. And then we also have self-compassion. So as Susie mentioned, that a risk factor for developing an eating disorder is quite high levels of self-criticism. And so it's kind of working with young people to think about how they can develop to be more compassionate to themselves, and sort of that thinking of, well, what would you say to a friend who is having this struggle? You know, would you talk to your friend the way that you talk to yourself, that sort of thing. And then finally, perfectionism. So supporting a young person to kind of understand their perfectionism and try and sort of reduce how kind of perfectionism, the role that perfectionism has in their lives, I guess. And then finally, just going through the NICE recommended treatment for binge eating disorder. So that is something that is separate to the family-based treatment things that we would offer. So the first line of treatment for children with binge eating disorder is actually the same as the treatment that is used for adults. And what that is a guided self-help program. So that's 9 sessions that is CBT informed, focusing on understanding what is keeping the binging going, and then reducing the binges. So in kind of contrast to the family-based treatment, the treatment very much for binge eating disorder is focused on changing that behaviour and not around sort of weight restoration or the sort of weight loss that's associated with it. It's very much thinking about the kind of binge behaviours, how they're kind of kept going and what role they have in sort of reducing those.
Thanks, Alice. That's fantastic. So we're just moving on to the last part of our sort of presentation this evening. And I just really wanted to introduce you to FREED, which we're really excited about. It's our early intervention pathway for young people and young adults. And it stands for First Episode, Rapid Early Intervention in Eating Disorders. So just to give you a little bit of information about what it is. So this is a care pathway that we launched in March last year. So it's just coming up to about a year. And it's an early intervention pathway that's for young people aged 16 to 25 with a first episode eating disorder and of less than 3 years duration. And you might remember that Alice earlier on in our talk was just talking about the importance of early intervention, and that the research that suggests that actually if the prognosis is poorer if somebody's had an eating disorder for 3 years or more without treatment. So I'm going to go into a little bit on the next couple of slides about the research behind the FREED pathway and why it was developed. But just to tell you a little bit about what it looks like in our team and our service. So we, you'll notice that asterisk there because actually at the moment we are offering it to 18 to 25-year-olds. And the reason that we're doing that is just because when we launched it, we wanted to really make sure that we were able to implement the pathway and focus on that age group. And for our 16 and 17-year-olds, because we have access and waiting time standards for children and young people, it means that the 16 and 17-year-old patients would be seen very quickly anyway. So we have standards that we work towards and we meet targets, which is where somebody would receive treatment within a sort of very short period of time. So we felt that actually it seemed sensible to start with 18 to 25-year-olds to make sure that we can really consolidate and make sure that it runs smoothly. But we do plan to open FREED up to the 16 and 17-year-olds as well. So we have a dedicated FREED team and we have a FREED champion who is a specialist eating disorder nurse. And we have sort of regular sort of FREED meetings, sort of a weekly FREED huddle, and we receive a triage So the aims are that I'm very proud to say that we have been meeting our targets, is that patients who are within the freed pathway will receive a triage call from an eating disorder specialist. So somebody, either our freed champion or our assistant psychologist within the freed team, or one of the clinicians within the freed team, within 48 hours of that referral. We really want to encourage people to be speaking with us so that we can really be proactive and really moving on to the next stage of assessment. Assessment will be within 2 weeks of referral, and treatment will start within 4 weeks. So the sort of research behind freed was very much based on the sort of research that we know around brain development, so that we know that the first 3 years when somebody has an eating disorder provides the critical window to effectively treat and reverse brain changes caused by an eating disorder. And I suppose what freed is doing is very much prioritising patients based on how flexible and malleable their brain is, rather than diagnosis and severity. So what we know is the longer someone is unwell with an eating disorder, the harder it is going to be for them to change. And I'm just going to go into why that is in just a little bit further down this slide. We know also that sort of eating disorders typically develop during adolescence and early adulthood, when we know the brain is still developing. So the average age of onset for anorexia is 16 to 17, and for bulimia it's 18 to 19. And yet we know the brain is developing up until the age of 25. So the research that has been carried out into sort of impact on the brain from, you know, when you have an eating disorder, and it's comparing brain scans of somebody with and without eating disorders, we can see that the eating disorders cause changes in the brain. One is that actually if somebody's very malnourished and someone's very, very low weight, the brain actually shrinks. But also the changes in the brain make the eating disorder behaviours much more habit-like. We know that it affects part of the brain that is involved in the formation of habits. So the eating disorder behaviours can become very entrenched and negatively affect the chances of recovery if we don't treat early. So offering treatment in the first 3 years can actually reverse these changes and improve the chances of a full recovery. So I think what we're looking at here is that we know that the eating disorder behaviours are initially quite rewarding. So if somebody's very anxious, we know that actually if you really restrict, that initially what they will notice is that it numbs their emotions, that actually anxiety is reduced. But then the behaviours become habitual, they become neurocognitively ingrained, causing brain changes, and the treatment outcomes are significantly worse for those who have had an eating disorder for over 3 years. So the aims of freed: 1 is to reduce the waiting times for treatment, 2 to improve outcomes for those with an eating disorder. We really want to, if people are underweight, we want to make sure that their weight restored quicker, that they reduce the eating disorder behaviours that can cause such a significant impact to physical and psychological well-being. But also we want to get people back on their normal life track again, to get them back into their, into things that they like to do, and to get back on track again, and to be able to work towards things that are important to them. So freed is about providing a service that's tailored to the specific developmental needs of young adults who have an eating disorder. And it's offering nice concordant treatment within 4 weeks of referral to an eating disorder service. This is just giving you a little bit of an overview and a summary of what the key parts of the freed service model include. And this is something that we're always within our freed team trying to focus on. And that's about, we want to make sure that we are really proactively engaging with people, young people, because we know that actually this age group, we know that actually is much more likely to drop out of treatment or might not think that they've got a problem. So what we want to do in that triage call is to really really encouraging people and saying that actually we think it's a really great thing that actually they've come to our service, and the importance of early change. So we really want to make it as easy to access our service as possible, to have a really informative website, videos where people can find out more about freed, and that's what we provide. We want to make sure that treatment is adapted to that age group. So it's person-centered, and it's centered on the stage of illness. It's flexible. It's not a one-size-fits-all approach, and it's really tailored to what their goals are as well. There's a really strong emphasis on early dietary change, because we know that the earlier somebody makes a change, the better the outcome. And that's something, again, there's so much psychoeducation with young people, with their families, about the importance of making those changes straight away. And that leads on to the next point, is a really strong involvement with the family. We really encourage that right from the get-go, is talking about how involving families can have a really important impact on outcome. So we, providing education to families, skills training, lots of support, because getting families on board to support their young person. And also really focusing on transitions. We know at this stage in life, when you're thinking about 16 to 25, there's an awful lot of change in terms of education, exams, preparing for uni, thinking about employment, but also other changes like living independently, moving out of home. So we're really making sure that we're focusing on the key areas of that life stage. And that brings us to the end. So I will stop sharing and open up to other questions if anyone's got any.